Hello class, and here is the voiceover PowerPoint for Chapter 1, Trends and Issues, as promised. Our objectives over Chapter 1 are to describe the subjective and objective ways that aging is defined, identify personal and societal attitudes towards aging, define ageism, discuss myths that exist with regard to aging, and identify recent demographic trends and their impact on society. Families had to produce many children to ensure that few would survive and reach adulthood. In many ways, children were treated like small adults. There was little or no concern was given to characteristics and behaviors that set one child apart from another. Why was the attention of healthcare providers focused on people between the ages of 20 and 65 years of age? Society also viewed adults of all ages interchangeably. Older adults now constitute a significant group in society, and interest in the study of aging is increasing. Question number 1. Until the middle of 19th century, only two stages of human growth and development were identified. They were A. Infants and older adults, B. Childhood and adulthood, C. Birth and death, or D. Illness and wellness. The answer is B. Childhood and adulthood. Aging is a complex process that can be described chronologically, physiologically, and functionally. Geriatrics deals with the physiology of aging and with the diagnosis and treatment of diseases affecting the aged. Gerontology is the study of all aspects of the aging process, including the clinical, psychological, economic, and sociologic problems of older adults. Gerontics, the nursing care and services provided to older adults. Gerontophobia is the fear of aging and the refusal to accept older adults into the mainstream of society. Both senior citizens and younger persons can fall prey to such irrational fears. Sometimes gerontophobia results in very strange behavior. Audience question number 2. Usually only the best and the brightest nurses and physicians seek career in geriatrics because of the increasing need for these services. A or B? True or false? Answer is false. Let's go over some myths versus facts. Seniors and younger persons can fall prey to irrational fears, which may arise from the fear of growing older. Discuss some common myths and corresponding facts related to aging. You can refer to your book, page 5, box 1-1, to look at all the myths and facts. Ageism. The dislike of aging in older people based on the belief that aging makes people unattractive, unintelligent, and unproductive. An emotional prejudice or discrimination against people based solely on age. It allows the young to separate themselves physically and emotionally from the old and to view older adults as somehow having less human value. What effect may ageism have on the way healthcare providers relate to older adults? Age discrimination reaches beyond emotion and leads to actions, results in different treatment of older people simply because of their age, and some older individuals respond to age discrimination with passive acceptance, whereas others join together to speak up for their rights. Try to think of some examples of age discrimination. Demographics. The statistical study of human populations It's concerned with the population size, distribution, and vital statistics. And demographics are used by the government as a basis for granting aid to cities and states, by cities to project their budget needs for schools, by hospitals to determine the number of beds needed, by public health agencies to determine the immunization needs of a community, and by marketers to sell products. The most inclusive demographic research in the United States is compiled every 10 years by the Bureau of the Census for the United States. According to the U.S. Department of State, the number of people over age 65 is projected to exceed the number of children under the age of 5. In 2010, an estimated 40 million people aged 65 or older lived in the United States. By 2050, this is expected to increase to 72 million people aged 65 or older. 1 out of 5, or about 20% of the total population of the United States. Individuals older than 85 years of age now make up about 4% of the entire U.S. population. The Administration on Aging projects that minority populations will represent 26.4% of the older population by 2030. Women currently outlive men by approximately 5 to 6 years. Women tend to live longer than men, and whites tend to live longer than blacks, although disparities seem to be declining. White women have the longest life expectancy, about 81 years. Baby boomers consist of people who were born after World War II between 1946 and 1964. They account for approximately 1/3 of all Americans today. Because of the baby boomers' size, this group has had and will continue to have significant influence on all areas of society. We are becoming an increasingly older society. The older adult population is not equally distributed throughout the United States. Climate, taxes, and other issues regarding quality of life influence where older adults choose to live. Population distribution data show that Florida leads the nation with 17.4% of its population being older than 65 years of age. Approximately 79% of older adults reside in metropolitan areas, with approximately 36% residing in principal cities. In 2012, 72% of men over the age of 65 were married, compared to 45% of older women. The percentage of married individuals drops significantly as age progresses. By age 90, 80% of women were widows, compared to only 49% of men. The percentage of older adults who are separated or divorced has increased significantly to about 12%. In 1970, only 28% of senior citizens had graduated from high school. By 2012, 81% are high school graduates or more, and 24% have a bachelor's degree or higher. Today's older adult population is more technologically sophisticated. The next section of Chapter 1 are objectives. We're going to describe the effects of recent legislation on the economic status of older adults, identify the political interest groups that work as advocates for older adults, identify the major economic concerns of older adults, describe the housing options available to older adults, and discuss the healthcare implications of an increase in the population of older adults. So, our poverty status, some of the poorest people in the country are older adults, but so are some of the richest. In 2011, approximately 9% of the elderly population was statistically determined to be at or below the poverty level. Older women were more likely to be impoverished than men. Older minority women, particularly blacks and Hispanics, were more likely to live in poverty. As of 2011, the median income of males over the age of 65 was $27,707, while that for females was only $15,362. The median income of households headed by a person 65 years of age or older was approximately $48,538. The major sources of aggregate income for older adults include Social Security benefits earnings, asset income, pensions, and other earnings. Approximately 81% of households headed by a person older than 65 years of age own their home. People older than 65 years of age generally have more discretionary income available than do younger people. Money left after paying for necessities such as housing, food, and medical care. Most older adults live with a spouse or alone. Older individuals often try to keep their home despite the physical or economic difficulties in doing so. It represents independence and security. Some older individuals remain in their own houses and refuse to give up long after it is safe for them to be alone. Independent or assisted living centers combine privacy with easily available services. Most consist of private apartments that are purchased or rented, and they have different levels of medical, nursing, and personal care services. Many centers have communal activity rooms, art and craft hobby centers, swimming pools, lounges, beauty salons. I don't know where I left off. So many centers have communal activity rooms, art and craft hobby centers, swimming pools, lounges, beauty salons, mini grocery stores, greenhouses, and other amenities. Transportation to church, shopping, and other appointments is provided by some of these facilities. For a large initial investment and substantial monthly rental and service fees, older persons or couples are guaranteed a residence for life. This is for life leases or life contract facilities. Independent residents occupy apartment units, but extended care units are attached to the apartment complex or located nearby for residents who require skilled nursing services. When the occupants die, control of the apartment reverts to the owners of the facility. Government and subsidized housing may be simple apartments without any special services, or they may have limited services such as access to nursing clinics and special transportation arrangements. Waiting lists of up to 2 years are common. Group housing plans. 2 or more unrelated people share a household in which they have private bedrooms but share common recreational and leisure areas, as well as the tasks involved in home maintenance. In some cases, a large house may shelter 10 or more residents. In some situations, younger adults who need reasonably priced housing may be included. Community-based residential facilities. For a monthly fee, this type of facility provides services such as room and board, help with activities of daily living, assistance with medications, yearly medical examinations, information and referrals, leisure activities, and recreational or therapeutic programs. Most of these facilities provide private or semi-private rooms with community areas for dining and socialization. Nursing homes or extended care facilities provide room and board, personal care, and medical and nursing services. They are licensed by individual states and regulated by both federal and state laws. Medicare is the government program that provides health care funding for older adults and those with disabilities. Most Americans older than 65 years qualify for Medicare. We have Medicare Part A. So Part A covers inpatient hospital care, extended care in a skilled nursing facility following hospitalization, some home health services and hospice services, but only after the patient pays an initial deductible and any copay expenses. Part B covers 80% of customary and usual quote-unquote rates charged by physicians after deductibles are met. Medicare Part C is your quote-unquote Advantage plan, which allows beneficiaries to receive Medicare benefits through private insurance companies that are able to demonstrate cost savings. Medicare Part D, this is their prescription plan. Prescription drugs are distributed through local pharmacies and administered by a wide variety of private insurance plans. Supplemental Medicaid may be available for those older adults who meet certain financial need requirements. Many of those who have assets do not qualify. They are left with Medicare Gap or Medigap, and they must pay themselves. Many older people buy private medical insurance, often at unreasonable prices, to pay medical bills that are not covered by Medicare. The Medicare program that provides for prescription drug coverage is A Part A, B Part B, C Part C, or D Part D. And the answer is Part D. So the rising costs during 2011, the Centers for Medicare and Medicaid Services, or CMS, reported that approximately $2.7 trillion was spent on health care in the United States. This exceeds the amount spent on any other activity, including defense, expected to grow to $3.9 trillion by 2018. A significant proportion is spent on older adult population, and we expect that population to grow, so it's just going to continue to grow. Legislative activity, we have the Patient Protection and Affordable Care Act. This was passed by the United States Congress in 2009. It includes numerous health-related provisions to take effect over several years. There is a great deal of controversy because many specifics of the legislation and their ramifications are still unknown. With the new presidential election coming up, you'll hear a lot of talk about this particular CARE Act and what the new candidates intend to do to help healthcare in the United States. It's interesting. Question number 4. More money is spent on healthcare in the United States than any other country in the world. True or false? The answer is true. A, true. And why do we think that is? Just something to kind of challenge you to think. We'll talk more about that in class. Costs and end-of-life care. 1/4 of all Medicare dollars are spent on services for 5% of Medicare patients in their last year of life. Most healthcare services are used for terminally ill patients. Serious questions are being raised about the appropriateness of using intensive, expensive interventions to extend the lives of terminally ill older people. Advanced directives. There's 2 formal types of advanced directives that are recognized in most states. Those are the durable power of attorney for healthcare. It transfers the authority to make healthcare decisions to another person or a living will, which informs the physician that the individual wishes to die naturally if he or she develops an illness or receives an injury that cannot be cured. These written documents are designed to help guide the family and medical professionals in planning care. Next part of Chapter 1 We have some objectives to describe the changes in the family dynamics that occur as the family members become older, examine the role of the nurses in dealing with the aging family, identify different forms of abuse, recognize the most common signs of abuse, describe approaches that are effective in preventing elder abuse. It is estimated that 80% of older adults who need care will receive assistance from their families. Middle-aged family members often become the caregivers. Typically, sons contribute financially, but the brunt of the emotional and the physical care burdens falls to daughters. Children often take care of older parents in their own homes when the older parent can no longer maintain their own houses or apartments. Caregivers in the United States, the average age of a caregiver is 48 years old. 66% of caregivers are female. 16% of American workers function as caregivers. The most significant issue that aging parents and their children must face is probably A, lack of housing, B, behavioral issues, C, loss of independence, or D, lack of support. And the answer is going to be C, loss of independence. The nurse and family interactions. Families are made up of human beings who respond to stress in many different ways. The older adults we care for are often very ill or infirm, and as nurses we tend to focus on their physical needs, cares, and treatments. In our preoccupation with our duties, we can easily lose our perspective of the older patient as both a person and a member of a family. Some families show a great deal of interest and concern for their aging members, visiting regularly and interacting with the patient and staff. Other older individuals may never have family members visit them. Self-neglect. It's defined as failure to provide for self because of lack of ability or lack of awareness. It's more likely to be seen when an older person has few or no close family or friends, but it can occur despite their presence. Most likely to be recognized by neighbors and reported to the police, public health nurse, or social worker. Often connected with some form of mental illness or dementia. Abuse or neglect by the family. Physical abuse entails any action that causes physical pain or injury. Neglect is a passive form of abuse in which caregivers fail to provide for needs of the older person under their care. Or emotional abuse includes behaviors such as isolating, ignoring, or depersonalizing older adults. We also have financial abuse. The resources of an older person are stolen and or misused by the person whom the older adult trusts. Or we have abandonment. That occurs when dependent older persons are deserted by the person responsible for their custody or care under circumstances in which a reasonable person would continue to provide care. Responses to abuse. Oftentimes they have a great fear of being treated even worse, or fear of being institutionalized or abandoned may prevent them from seeking help. All questioning about and assessment of abuse must be done with great tact and sensitivity. So some signs of elder abuse include, you can refer to box 1-6 on page 24. Some signs include they demonstrate excessive agreement or compliance with the caregiver. They show signs of poor hygiene such as body odor, uncleanliness, or soiled clothing or undergarments. They are malnourished or dehydrated. They have burns or pressure sores. They have bruises, particularly clustered on the trunk or upper arms. They have bruises in various stages of healing that may indicate repeated injury. They lack adequate clothing or footwear. They have inadequate medical attention, or they tell us that they have a lack of food, medication, or care, or they tell us they're being left alone or isolated in some way. Maybe they tell us that they are scared of their caregiver. And if they tell us that they have a lack of control in their personal activities or finances, those are all signs of elder abuse. People who are hired to provide for the safety and well-being of older adults can sometimes become their greatest threat. There are specific federal and state laws designed to prevent undesirable persons from contact with vulnerable people, such as the young and the older adult population. Sometimes people with criminal records, inadequate training, or other serious shortcomings manage to gain employment despite safe regard. Nurses who supervise other caregivers must constantly be on the lookout for abusive behaviors. Any indication of abuse in an institutional setting must be reported as soon as it is suspected so that the appropriate action can be taken and the abusive person removed. The importance of this nursing responsibility cannot be stressed enough. There's some examples of abusive behaviors in the healthcare settings in box 1-7 on page 26. Abusive behaviors in healthcare settings include use of sedative or hypnotic drugs that are not medically necessary, use of restraints when they are not medically indicated, use of derogatory language, angry verbal interactions, or ethnic slurs, withholding of privileges such as snacks or cigarettes, excessive roughness in handling during care or during transfers, delay in taking a resident to the bathroom or allowing a resident to lie and body waste, consumption of the resident's food, theft of money or personal belongings, physical striking, or any other assaultive behavior of or towards a resident, a violation of a resident's right to make decisions, and failure to provide privacy. Support groups. Caregivers who want or need to share their experiences and frustrations have started forming support groups to help each other cope with the stress. Support groups allow caregivers to share their feelings and learn new strategies for improving their coping skills. Respite Care allows the primary caregiver to have time away from the constant demands of caregiving, thereby decreasing caregiver stress and the risk for abuse. It gives the primary caregiver the opportunity to attend his or her place of worship, go shopping, conduct personal business, obtain medical care, and participate in other activities that most people take for granted.